Yes. So I'll pass on the floor to Dr. Ip for his presentation.
Thank you, Shravan. Ladies and gentlemen, thank you for having me today. We also have an audience across the internet. We've got a colleague in Rodrigues and a few friends in UK, so I say hello to them as well. So today, the outline of the talk, obviously you've guessed we're going to talk about the diabetes, the kidneys, and the SGLT2 inhibitors. But I don't like going through loads and loads of slides of trials. I just want to take some step back and to look at the global perspective and also some local data, and also look a bit at where we have come from in terms of history, how we're doing now, and where we are going. And we've known about diabetes for a long, long time. And the first mention was in the ancient Egypt civilization, 1,552 years before Christ. There was a mention on the papyrus of a disease causing passing a lot of urine. It is possibly the earliest known record of diabetes. The ancient Hindu were very advanced in terms of their Ayurvedic medicine. And Sushruta and Charaka, one of them is one of the fathers of Ayurvedic medicine, noted that some patients had urine that attracted ants, and it was called Vadumia. The Chinese came a bit later. They also described something called wasting thirst, that caused excessive thirst, hunger, urine, and weight loss. The Greeks gave the name diabetes, which refers to a siphon, but they never actually described the properties of urine as being sweet. The mellitus was added to diabetes almost 1,000 years later. We also have the Persian polymath Avicenna or Ibsina, who also described many features of diabetes mellitus. And we need to wait until Matthew Dobson from England, who evaporated urine and found a brownish sugary substance, which was sweet. I saw on the net that he said that sugar was sweet, so I wonder whether he actually tasted the blood. It's not something we would do now. He also noticed that there were two groups of patients. In some patients, diabetes was fatal within a few weeks, whereas in others, it seemed to stretch over many years. And it's probably the first inkling of type 1 and type 2 diabetes mellitus. I've got a little note of 1798, John Rollo, Scottish army physician, who made a publication of 2 diabetes cases he saw 19 years apart, whereas now we probably see 2 patients 19 minutes apart. In 1869, Paul Langerhans, a German, described the islands of Langerhans, now called Langerhans in the pancreas, which is we now know is the source of insulin. And 2 German, Minkowski and von Mering, did an experiment that would attract a lot of anger now, removal of a pancreas from a dog, and that resulted in diabetes, sugar appearing in the urine. Now we come to the turn of the century, and we've got 2 Americans, Frederick Allen and Dr. Jocelyn, who did a lot of clinical work. They described various kind of diet, including starvation diet, which seemed to help type 2 but kill type 1. Jocelyn has lived for many years until his 90s. He's an icon of American diabetes medicine. He did the first diabetic registry. He predicted the pandemic we're having now. He started glucose monitoring. And when he did his registry, he went through, I can't remember numbers, I think many decades of records, of case records of a Massachusetts hospital. And basically, the first 70 years, there were very few cases. And then in the last 20 cases, he saw a lot of diabetes. And although the message, although we knew about diabetes for a long time, it was a rare disease until the mid-1850s. From then on, something has changed, and we now know it is a pandemic. In 1921, Canadian Banting and several assistants discovered insulin and injected it in the first patient, John Thompson, and they got the Nobel Prize for it. This slide shows the various treatment we have for diabetes. The first drug, granidine, was from a derivative of French lilac, but it was toxic to the liver. But many, many years later, that led to the discovery of metformin. But looking back at the history, what is surprising is that insulin started for many decades before we got the first real oral anti-diabetic agent. And we can see from 1995 onwards, we have a number of new classes of drug, and including the latest one, the SGLT2 inhibitor. I hope that you've read quite a few journals about the epidemiology of diabetes and other metabolic diseases. And you might have noticed the studies about the Pima Indians. The Pima Indians live in Arizona, not too far from the Grand Canyon. And initially they lived in a very hard condition. They were farmers mainly, they did some hunting. And obviously they had a very minimal diet, subsistence diet. They did a lot of work and everything was okay until they came into contact with the Westerners. And initially there were some doctors who described, but they didn't mention any diabetes. Eventually they were moved from their original settlements and moved to reservation, and they changed their lifestyle, and there was a huge increase in diabetes. And in 1978, there's this paper that said that they had the highest prevalence rate of diabetes in the world at 21.1%. And of Mauritius now, we're at 22%, some 40 years later. But this pattern of sudden increase has occurred in many parts of the world. The graph in the lower left is the numbers for Pennsylvania in Philadelphia. And if you look at many parts of the world, they've gone through that different times. It is true for the Inuit, the Eskimos, people living in South America, in the different South Pacific islands. In China, the prevalence of diabetes was 1% in the 1980s, and now it's about 10%. And we're seeing the same thing in India as well. So these are the numbers. I'm sure you've heard about it. And this is the consequence, which is absolutely awful. And this is a slide everybody talking about diabetes like to show. This is from the International Diabetes Federation, Atlas of Diabetes. And we are in the, well, we are really in the African region, but we often, our data is put in Southeast Asia by the International Diabetes Federation. Anyway, in all parts of the world, there's huge increases, but the increases are more moderate in Europe and North America and Caribbean, and the rest of the world is very, very fast. And in the World Diabetes rankings, we are 5th. And I think a few years ago, we were 3rd or 4th. But if you look at the projection for the next few years, we'll be at 24 and 25. So we're fighting for second place. The other striking thing about this slide is a number of island nations, like Marshall Islands, Kiribati, New Caledonia, Solomon Islands, Guam, and so on. So why do small island nations get so much diabetes? And in terms of impaired glucose tolerance ranking, we are still quite high up. And again, why? Papua New Guinea is number 1 in this chart, and of note, Papua New Guinea is the place where sugarcane was first cultivated. And it's from there that it spread to Southeast Asia, India, and then to the Middle East, and eventually Europe. And of course, sugar became a big commodity in the 18th and 19th century. And it's clear that it has led to the diabetes epidemic. This is local data from the NCD survey from 1987 to 2015. And you can see the gradual increase in diabetes from 15% in 1987 to 22%. You can note that initially there were a bit more men than women, and later maybe more women than men having diabetes. I'm not sure it's a real trend or not. It would be interesting to see the next lot of data. This chart from the survey shows the different groups of HbA1c. And we can see that we have quite a lot of above 10%. We can note that people on insulin are mainly in the high HbA1c group, suggests that insulin is not working. And really, we're in a big difficulty in Mauritius, especially in the the public sector, where we are limited to metformin, sulfonylurea, insulin. This chart shows the national history of diabetes, type 2 diabetes, which starts with a decline of beta cell function. And initially it's accompanied by both an increase in insulin secretion to compensate and also insulin resistance. But eventually there is a degree of beta cell failure and there's a decrease in the insulin secretion. And as we go along, we move from pre-diabetes to type 2 diabetes with macrovascular and microvascular complication. And this shows a similar thing, but with addition of the features of macrovascular disease, so atherosclerosis, hypertension, there's also cardiovascular disease, of course, and then we have the microvascular complication, retinopathy, nephropathy, and neuropathy, and eventually lead to organ failure, blindness, renal failure, heart disease, amputation, and death. The front row is a researcher who has written a lot on the different pathologies in diabetes. He wrote this article in 2009, giving great detail about the mechanism, but he also seemed to have some fun with the titles of the various subsections. He described how initially we only knew about beta cell dysfunction, muscle and hepatic insensitivity to insulin, which I call the triumvirate. And that was increased to disharmonious quartet with adipocyte dysfunction, and then to quintessential quintet with an incretin effect in the gut, the cetaceous sextet, hypergluconemia, septicidal septet, altered renal glucose handling, and ominous octet with CNS dysfunction. And this is the same thing in graphic form. And we can see that all the classes of drugs are supposed to act on different aspects. And we can see on this chart that the thiazolidinediones act on 4 sites, but we now know that they do not work very well, and especially they can cause cardiovascular morbidity. And the SGLT2 initially was thought to act only on the kidney. And of course, the danger of going with fancy number-based sentences that someone else will come and trump you. And Schwartz et al. Came with an egregious 11. They added a microbiome dysfunction, immune dysregulation, and increased small intestine absorption of glucose due to amylin. From the renal point of view, this diabetic milieu is definitely bad for the kidney because it causes glomerular hyperfiltration. It causes structural changes to the podocytes, to the glomerular basement membrane, and the main result is proteinuria, glomerulosclerosis, and eventually loss of glomeruli, and also damages the tubule. And this chart shows the classical natural history of diabetic nephropathy. I would hope you're quite familiar. So as soon as we get diabetes, there is an increase in GFR of about 20 to 30%. And this very often disguises the impending decline in renal function. Doctors and patients are very happy that the creatinine is 60, but really that's already the first stage of diabetic nephropathy. So the GFR eventually declines with the albuminuria going first in the microalbuminuria range and then into frank proteinuria and eventually nephrotic range, which occurs quite late. An important thing we all know is that microalbuminuria will come quite a lot earlier than an increase in creatinine. And if we didn't have any treatment for diabetes, what would be the rate of loss of renal function? And a lot of information comes from the study of these Pima Indians I mentioned earlier. And they've been in a longitudinal study since 1965. And one of the most interesting paper that came out, I don't have the date here, I think it's about 15 years ago. They looked at the Pima Indian in Arizona, and they found that the diabetes prevalence was now 38%. And they also looked at another group of Pima Indian, which was separated from the American group. They live in Mexico, in a mountainous area, and for a long time it was almost impossible to go there. Had to go through a rope ladder to reach there. Only recently they have a road with a lot of hairpins, and they were able to join civilization, and the doctors could go and study them. There are also some non-Pima Indian in the area, and the diabetes prevalence rate in the non-Pima Indian is 2.9%, and for the Pima Indian, 6.9%. So what is the difference between the two groups? The people in Mexico work very hard and don't eat a lot, whereas the American Pima Indians live a full American life. Now, a lot of experiments have been done, and we know that this graph is from kidney donors for transplantation, but we have our peak GFR at the age of 20, and from that on it's a gradual decline with age of just under 1%, probably 0.8%. This graph shows first the top line is inulin, so it's the gold standard way of measuring GFR. The lower down is using a equation. It is now clear, however, that not everybody follows the classical natural history of diabetes nephropathy. About a quarter to 1/3 will not have proteinuria, not even microalbuminuria. And what we see is that GFR declines in steps, suggesting that maybe there is a ischemic component to the disease. And one of the scary things about diabetic kidney disease is that we recognize it very late. The top row shows in blue the percentage of diabetic kidney disease that is undiagnosed. And we can see that we virtually don't recognize any in stage 1. The number decreases gradually, but even in stage 4 and stage 5, about 40% are not diagnosed. And this is very serious because we know in the world we also have an epidemic of end-stage renal failure. The numbers are projected to double in the next 20 years in all the areas, especially in Asia. And the main cause of kidney failure is diabetes. I've shown these two bits of data many times in previous lectures. The first one is from American data. They look at 1,000 plus adults and look at their blood records and followed their course in admissions and hospital admission for the next few years. And they found there was a clear correlation between their eGFR and the rate of admission. And you can see that if you are in stage 5, less than 15, you've got 14 times the risk of dying. And in stage 4, it's 11 times, and stage 3B, 4.7. So the cutoff mark is 45 mils per minute. This is why stage 3 was eventually divided into stage 3A and 3B when this data came through. And another look at the same data is really similar numbers. But if you look at stage 4, you have a 45.7 chance of dying over 5 years, about 10% a year. And at that time, dialysis was 20%. So you had a lot more chance of dying than going on dialysis. But I think the latest studies show that this has changed. And we now know that more people survive dying than they go on dialysis. And on dialysis is also a very difficult time because the mortality rate is very high. The orange line is the mortality for dialysis. You can see bang in the middle of different cancers. I see Dr. Moit is here, oncologist, but dialysis is worse than breast and colorectal cancer in terms of survival. This graph shows the number of dialysis patients in Mauritius. It's increasing and increasing, and the latest figures is just shy of 1,400. Earlier this year was an important paper. It's an international effort, an epidemiological effort. Unfortunately, we didn't pay attention because we were too busy looking at COVID-19. And this team looked at the epidemiological data from different countries and through various calculation and estimation came with figures of CKD burden in all the countries in the world. And this one shows the age standardized rate of disability adjusted life years as a measure of a disability due to CKD. And we are in red here, and we are in good company with the same people who have a lot of diabetes, the island nations. And we're actually second for this measure. And this is one of the many pages of tables. And we can see the global rate for CKD, it's 8,724 per 100,000 with a mortality rate of 15.9. I will spare you looking at all the countries, but if you look at Mauritius, we're 13,768. We are actually second for this, behind Fiji. And for the death rate, 67 per 100,000. We're second again, this time behind El Salvador. El Salvador is also first for the disability adjusted life years. So this is the top 10 countries for prevalence CKD and deaths. And again, lots of small island nations. And then we can also see some South American countries. And the USRDS do international comparison. There are no figures from Mauritius. It's something we need to change. We need to have a registry. But this shows the new patients being added to dialysis every year. And Taiwan has been top for many years, 493. I'm not very sure why, because they do not have the highest rate of diabetes in the world. They are somewhere 1/3 down. And we've calculated the figures for the same year, 2016 for Mauritius. And we have 680-ish patients. And when we divide by our population, we get 540. We are number one by far. And this should not come as a surprise if we look at the Lancet figures from earlier. They all seem to tally. And if we look at prevalence of treated end-stage renal failure, we are not so high up. We are about 15 and 1,250. Taiwan is still first, 3,392. So there's a bit of a discrepancy between these two figures. And I'll let you work it out why the numbers are different, why we have so many incident patients, but our prevalent population doesn't seem to increase that quickly. I'm ashamed to say that we do not have figures, Mauritius, to say what's the percentage of patient on dialysis have kidney failure due to diabetes. We know it's at least 60%, so we might be in line with Malaysia and Singapore and Mexico. We have to be very careful with data because it all depends how we collect it, how we define the different parameters. This is data for Mauritius. This is the data for circulatory disease and diabetes. We moved from ICD-9 coding to ICD-10 coding and in 2005, and suddenly there was almost a switch with diabetes going to about 23%. The 2018 figures are still about 23% mortality diabetes. If we look at the same report, we look for renal failure. We have 62 deaths in Mauritius in that year. And the Lancet estimates that 1,000 deaths due to kidney disease. Of course, they're not all dialysis patients. And clearly the way we are coding, we're capturing information is wrong. And we are missing a lot of data. And certainly it's not giving renal disease the visibility that it should be having. And this is a whole part of a big problem. You know, racism, we have renalism, where we exclude renal patients because they have renal failure. We cannot include them in major trials. We have to have exclusion for them. We do not give them angiography. We don't give them contrast and so on. Now we'll talk about apples and SGLT2 inhibitors. I showed you a history of diabetes, how insulin came in 1920. Actually, the work on SGLT2 started far earlier. It started in the early 1835 there from a Belgian, de Koning. Him and his assistant received a huge pile of apple roots from a professor of botany, and they played with it and they managed to extract a substance which is called florazin, which is a glycoside, and they initially tried to use it as an antipyretic. They were not very successful. But eventually von Mering, I mentioned von Mering earlier, he's the one who removed the pancreas from a dog, but quite a few years earlier, he injected florazin into dogs and found that it caused appearance of glucose in the urine. He also recognized that this kind of diabetes or sweet urine was different from the removing the pancreas from the dog. So the SGLT2, how do they work? They inhibit the sodium glucose co-transporter in the kidneys. We have the SGLT2 in the top part of the proximal tubule and the SGLT1 a bit lower down. And in normal times, the SGLT2 are responsible for absorbing 90% of the glucose. So the SGLT1 lower one, about 10%. And when we give a drug to inhibit the SGLT2, then obviously there will be more glucose appearing in the urine. But in practice, it's rare to be able to reabsorb more than 60%. So we lose 40%. And this is because SGLT2 inhibitors, who normally don't work very hard, take up the flat, they are upregulated as well. And when we lose glucose, we lower blood pressure, also cause a weight loss from a calories loss, and reduced uric. And we know that the ACE inhibitors causes a fall in GFR and glomerular pressure by dilating the efferent arteriole. But the SGLT2 inhibitors cause an afferent vasoconstriction. And initially that caused some nervousness, because we know that non-steroidal also causes afferent vasoconstriction and with very bad effects in kidneys. So the question for a long time is, can we give SGLT2 inhibition and with an ACE inhibitor or ARB, and would that be helpful to the kidneys? Let's look at just what was causing the problem. And one of the important ways SGLT2 work is through tubular-glomerular feedback. Normally, when we have sodium appearing in the proximal tubule, it goes through the loop and goes through the distal tubule and then goes through the juxtaglomerular apparatus. We've got osmoreceptors and macula densa that senses it. And if there's a lot of sodium, the body feels we're losing too much sodium, we need to reduce that. So they reduce, it causes afferent arterial vasodilation. And so that decreases GFR, and therefore less sodium is filtrated and less sodium is lost. But in diabetes, this mechanism goes awry because there is, among many things, an upregulation of the number of SGLT2 inhibitors, SGLT2 receptors. So instead of losing more glucose, we are absorbing more glucose back into the body. And what the SGLT2 inhibitors do is to restore the normal tubular-glomerular feedback. So it does have an impact when we eat because it reduces the post-meal glucose levels. Now, the SGLT1 receptors also present in other parts of the body, the brain, the heart, and so on, and the gut. And one reason why fluorescein, I forgot to mention, didn't work is that it was metabolized quickly, but also causes severe diarrhea because it had a marked, in fact, effect on the gut. But there's a thought that if we had some SGLT1 inhibitor that would block the absorption of glucose in the gut, and that could help. So that's the basis of some dual SGLT1, SGLT2 inhibitor. Canagliflozin is mainly SGLT2, but it has some SGLT1 action, and we have sotagliflozin, which is going through the trials, who has a bit more of SGLT1. Now, through all these years of development, they didn't know that these drugs would be a success, but there was an important indication that it wouldn't be really dangerous, because for some time we knew there was a condition called familial renal glucosuria. There are many types, and one of them is due to a genetic defect coding for the SGLT2 inhibitor. And we don't have to go through the detail, but there is this interesting paper which describes one case of pure, complete SGLT2 inhibition in this guy who loses all the glucose. Important thing, this guy is quite well. The only ill effect is that his puberty was delayed, but he still reached normal growth. And this is the problem facing kidney doctors. All the trials do not cover our patients. That's part of renalism. And the same thing happened for SGLT2 inhibitors. It was thought anyway that it wouldn't work in renal patients because they do not have GFR, so it cannot work on the tubule. And now to see where the SGLT2 is on the scale of diabetic treatment, in the 1990s, we had a number of trials looking at diabetic control. They gradually tried to tighten it. And basically, we reached buffers. In 2008, we discovered that HbA1c of 6% was too tight, but obviously a bit higher than that is good to reduce microvascular complication, including kidney disease. And then we went through the same process with ACE inhibitors, which was a major success, and then the ARB, and then they tried to mix them up, so candesartan with lisinopril together, so the lower dose seemed to be okay. And then we again reached the buffers in 2008 and 2013 with combination with increased risk of AKI and hyperkalemia. So as a change in tack, there was an introduction of a direct renin inhibitor, aliskiren, and initially okay, and then they tried to combine it with the previous drugs, and again, it was too dangerous. And they tried a number of other drugs, silodexide, which is a glycosaminans plus heparin combination, didn't work. Avosantan, antifibrosis agent, baracalcitol, vitamin D analog, botoxolone, NF inhibitor, no. So for many years, there was nothing until we had the SGLT2 inhibitors, and the first indication was when it was canagliflozin was compared with glimepiride, and we saw that it arrested decrease in GFR. And these early trials showed an average increase of HbA1c, some weight loss, decrease in blood pressure, some changes in lipids. There's a recent meta-analysis showed there's no significant change. We're not sure what it means, but there was very low risk of hypoglycemia. And we know that because the kidney and the liver has increased gluconeogenesis. So the first one to come out was EMPA-REG, which showed very modest HbA1c reduction, but there was a marked decrease in cardiovascular death and hospitalization. And then came Canvas in 2017, and you can see through the graph for heart failure and MACE outcome, a similar picture to EMPA-REG. The decrease in all-cause mortality wasn't as convincing. And the first indication that it might do something good to the kidneys in terms of the reduction of the progression of albuminuria, but also causes, in some patients, regression, decrease in albuminuria. And this shows the different odds ratio for the cardiovascular parameters, and all that was good side of the graph on the left, and the renal ones as well. And if we compare with empagliflozin and EMPA-REG, they are more or less the same picture. The main thing to note is that the SGLT2 do not seem to help in stroke in general, but they are very good for heart failure and for the renal parameters. This big graph tries to compare with the other class of diabetic agent. The DPP-4 inhibitors are quite safe, but they've been quite disappointing in terms of cardiovascular and renal endpoints. GLP-1 show more promise, but it's not uniform across the different preparation. We need more time to understand whether they will be really be helpful to the kidneys. I need to mention the third agent, dapagliflozin, and again they had a similar picture to the first two. And still keeping with dapagliflozin, this is a very nice graph. It shows that there is very clear evidence from these early trials that the renal and the heart failure effects are quite pronounced, but more modest advantages for actual MIs. So the advantage seem to be more in secondary prevention rather than primary prevention. This unfortunately projects very poorly, but the first bit shows that HbA1c lowering works very well in patients with a GFR of above 90, and then it decreases as the renal function decreases as predicted. But what is notable in the second one is the effect on weight. There's no clear change. And in the third is lowering of blood pressure. And instead of having a decreased effect with a worsening of function, you actually seem to, if any, have a better lowering effect at lower GFR. So an important clue that these drugs are really good for the kidneys. This slide shows a meta-analysis, a combination of all the data, from Declare, Canvas, EMPA, and CREDENCE lower down. And so we can see that there are a beneficial effect on loss of kidney function, reaching end-stage kidney disease or renal death, whether you are in above a GFR of 90 or 60 to 90, 45 to 60. And in the case of canagliflozin and empagliflozin, we have also data for people below 45. 2019, CREDENCE came, and this big slide shows a lot of good news. So lower graphs for canagliflozin for primary composite outcome, renal specific outcome, kidney death, dialysis, and renal failure, and also cardiovascular disease. I'm sure you've seen these figures, so I'm not going to spend too long. There's a very clear benefit for albuminuria. And of note is, I didn't pay attention earlier, but the effect on GFR, there's this decreased fall which due to hemodynamic effects is fully reversible. However, this led to a lot of fear at the beginning, but could be lead to acute kidney injury. But what we note after this initial fall, the slope steadies, and we have a much lower rate of decline of GFR, much less than placebo. And if you exclude that initial drop, you have a fall of about 2 mils per minute. But CREDENCE will also look at cardiovascular outcomes. So it works in primary and secondary prevention, though it's more favorable in secondary prevention. And the important thing to say that in CREDENCE, compared to the previous 3 trials, is that we are looking at patients who are more ill in terms of their kidneys. They have, on average, a lower GFR and have higher albuminuria, and therefore they have higher rate of disease, and you might have expected for it not to work as well. But you can see that from what I've shown earlier, that we still have is about 25% improvement. Now, what is this about the safety of canagliflozin? I can show you now that there is no increase of renal-related acute events, whether it's hyperkalemia or acute kidney injury. There's been a lot of fear for a long time. This is a very, very recent review from 1 week ago. We say we can finally stop worrying about acute kidney injury. Although there are the odd reports, like the one from 3 weeks ago about osmotic nephrosis and acute kidney injury, presumably due to the very, very high concentration of glucose in urine. But this is very rare, and it's not how we would have expected gliflozin to cause kidney injury. Other adverse effects is mycotic infection and urinary tract infection. In terms of malignancies, there's a bit of noise in the data, but there are, for renal cells, seems to be quite good. Slightly increased pancreatitis, and very early on it was noted that there was an increased rate of diabetic ketoacidosis. And again, this is just appeared yesterday. Thank you for Dr. Bicari for pointing that out. We've done a meta-analysis, and we found out that there is about a 3-fold increase in diabetic ketoacidosis, which can happen with normal glucose, so it's called euglycemic ketoacidosis. And the important thing is to be safe, to tell patients to stop these drugs when they are acutely ill with diarrhea, vomiting, when they need to starve, like admission to hospital for surgery, with sepsis. And probably we need to be careful with prescribing these drugs in patients who are relatively thin and have a very low carb intake. Amputation was a big weight on canagliflozin since the CREDENCE trial, but since the CANVAS trial, but in CREDENCE, there was no significant increase in lower extremity amputation, but we still advise to be very careful with people with peripheral vascular disease. So this is from a KDIGO, which summarizes the things we need to do now with patients with diabetic kidney disease. And all that is pretty straightforward. So when I last mentioned the PIMA Indians, I forgot to say that all these studies noted that the decline in GFR in these patients, if we did nothing, was about 10 to 12 mils per minute loss per year. And with ACE inhibitors, we managed to bring it down to about 5 to 6. And the good news with the gliflozin, it's about 2 mils per minute if you exclude that initial dip. And normal aging is about 0.8. So there's a huge progress we've done over the years. This is the American Diabetes Association protocol. We're not going to go through that, but we can note that SGLT2 inhibitors have shot up to the top of the treatment chart. And if the heart failure CKD predominates, it's number one choice. If it's atherosclerotic cardiovascular disease predominates, that is second best. Or we could have a lecture on the different mechanisms of how the SGLT2 inhibitors work. We'll spare all that. So it works on excretion of sodium and so on. One thing that attracts me is the superfuel hypothesis. It decreases the use of carbohydrates and makes the body produce more ketone bodies, and that's used as fuel. And this is reckoned to be protective to the heart and the kidney. And of interest, one of the fashionable diets is a ketogenic diet, and low carb diets where people produce their own ketones. Is there a connection? I don't know yet. And there are many proposed effects on the kidneys. The most important one is the reduction in the intraglomerular pressure that reduces hyperfiltration, and we'll discuss hyperfiltration a bit more. But generally, we also think that the SGLT2 inhibitors help the heart and the kidneys by reducing the energy requirement. By doing that, it reduces hypoxia and oxygen stress. The other thing we know is that there's increase in hematocrit, and not only through volume reduction, but also for an increase in the production of EPO. And there's this very interesting study that came out in May 2015. They're trying to suss out the mechanism of SGLT2 inhibitors in real people. So they've taken 20 people and they started them on empagliflozin and a loop diuretic, and then they were crossover to their normal medication, which also includes loop diuretic. These patients are diabetic, they're quite old, and they're obese with some degree of heart failure. And they did a lot of fancy tests, including measuring their plasma volume, the technetium label albumin, and also heavy water to look at total body water, and a lot of fancy complication experiment. And they came to the conclusion that they really increased sodium excretion with SGLT2. But there was a decrease in GFR, we know, due to hemodynamics, but also there was a sustained decrease in blood volume during the period. And that is a real diuretic effect of SGLT2 inhibitors. And there's a weight loss, which is partially fluid and partially fat. Now going back to the observation we made about why some countries seem to have more diabetes, the small islands, the third world. There were lots of theories. One of them was a 50 gene hypothesis, where people are going through cycles of famines will develop a 50 gene. There's many attraction to, with that, but you would have thought initially looking at that when you need to go through many generations to set the gene. I need to mention Brenner, which is a big figure in nephrology. I went through the slides of the important trials in diabetic kidney disease very quickly. You might have noted that there was a study on losartan called Renal. He was one of the investigators in it. But his big work is doing lots of experiments on rats at the beginning, including removing one kidney and poisoning a kidney with various agents, and looking what happened at the other kidney. And from that, he devised the hyperfiltration theory. And from 1971 to 1996, where he pieced everything together, that's 25 years of work. So the Brenner hypothesis is that through nephrectomy or various kidney disease, or we'll see other events, will reduce the number of nephrons in the kidney. We have 1 million in each kidney. If we have less nephrons, then the remaining nephrons will have to do the same work, but for decreased surface area. It's obvious then there will be more fluid going through, more volume and more pressure, so there is hyperfiltration. So we have an increase in single nephron GFR at the beginning to try to keep the overall GFR the same at 120, despite, let's say, 20% loss in number of nephrons, the remaining one will go 20% harder. So this causes glomerular hypertrophy and hyperfiltration, and hyperfiltration is bad for the kidneys. The other second B I want to mention is David Barker, who had this wonderful idea in the 1980s to look at people with kidney disease in Shropshire coming with heart attacks, and went back to their birth records to look at their birth weight, and he saw a correlation between low birth weight and increased mortality from heart disease. And basically we found the same relationship for various things, including the size of kidneys and number of nephrons at birth, kidney disease later in life. And therefore we can combine these two B's to say that if you, through a Barker, a developmental problem, you're born with less nephrons, then you will have hyperfiltration. And hyperfiltration will lead to kidney disease and then cardiovascular disease and so on. Of course, there are many other causes of hyperfiltration, including diabetes and any kidney disease that reduces nephron number. And this theory is still present. This is, again, just yesterday, long-term renal disease after prematurity or fetal growth restriction. But this is quite extreme. Most people are not born with premature or with growth restriction. In this group, we need a second hit to cause renal disease. And we can imagine that for the people with more subtle abnormalities at birth, there would be several hits to cause kidney disease. So the developmental theory of metabolic disease, look at the third B, at birth, lots of things have already happened, because during the time as a fetus, the mother's health is very important, the placental health is very important, and this will affect the development of various organs which lead to all these metabolic diseases. But it's a bit, at first when these theories come in, it's a bit difficult to know how does it actually happen in practice, and it's where the more recent understanding of epigenetics helps us. So we can have changes in through the DNA sequence and how many DNA genetic diseases are transmitted But we now know that many conditions are related to more subtle changes in the DNA. For example, methylation of DNA or changes to the histone, which is a structural protein that holds the DNA, and so on. And various conditions like diabetes will cause methylation or cancer and so on. And this is usually very often a one-way change. And once you do that, the genes are either activated or inactivated, leading to metabolic disease. And we can see how all this fit together. But things happening at birth, in the womb will have effect after birth. And we need to remember the impact on the future generations, not only the mother who's ill affecting the fetus, but also the fetus already has either the sperms or the future ovaries for the next generation. So it's 3 generations affected at once. So we can imagine from piecing all together how people who live in difficult conditions, in small islands, in various remote areas in the world, and then having a sudden change in their lifestyle through diet and work, can go through this cycle of epigenetic change, which is driving disease nowadays. And the question is, can it be reversed? Or can we just slow it down? Now, we've talked about SGLT2 as being useful in kidney disease and cardiovascular disease in the context of diabetes. And there are more trials coming looking at heart disease outside diabetes and kidney disease outside diabetes and other drugs that can be useful in diabetic kidney disease, and as well as the GLP-1 as well. There's some more trials coming. And there's also we are still waiting a trial for ceftazidime, which was refused FDA license for type 1 diabetes, but it was accepted in Europe. The big question mark is the rate of diabetic ketoacidosis. DAPA-HF came last year, and the main point about this trial is it looked both at patients with with diabetes and without diabetes and heart failure, and there was an improvement in the primary composite outcome of worsening heart failure and death of CV cause in both groups, and also death and hospitalization and death from any cause in the secondary outcomes. Just to say that with Vertis CV was announced a couple of months ago at Chugli-Fosen, and it's quite disappointed. They just managed to show that they do not cause increased cardiovascular events, but there was no clear benefit. We don't know why this is so. Now, for the nephrologist, what's exciting is the dapagliflozin CKD trial, which is looking at patients with both diabetes and no diabetes kidney disease, excluding polycystic kidney disease, lupus, and ANCA. And it was announced about 2 months that it stopped early. And it was just announced yesterday that they've met all their targets, primary outcomes and secondary outcomes. So I think we'll continue to trickle the good news in the next few months. Looking forward, we have EMPA kidney, again looking at non-diabetic kidney disease, and the difference is that they're looking at a wider, broader CKD population, not only with A3 macroalbuminuria, but also A1 and A2, and they're also going as low down as 20 mils per minute per eGFR. So at least they are not being renalist. There are lots of things happening with SGLT2. It's difficult to keep up, but apparently it can be helpful in certain kinds of cancers. It slows it down. It might be used for lithium toxicity, for obesity, for SIADH, refractory hypomagnesia, fatty liver, and so on. So after all this, who owns the SGLT2 inhibitors? No longer the diabetic doctor, but also certainly the cardiologist and the nephrologist, and possibly all doctors. So are we happy reaching a GFR decline of 2 mils per minute per year? I think we should always aim higher. Is anything coming? There's always lots of molecules being tested. There's one we know that we can expect good news is the third generation mineralocorticoid receptor antagonists, finerenone, which they've just announced they stopped the trial earlier this month. So the first drug in this category was spironolactone. We know it as a potassium-sparing diuretic, and it was eventually discovered after 20 years that it could help the heart, but the price was hyperkalemia and gynecomastia. And then came eplerenone, which had less of the sex hormone effects, but still had hyperkalemia. And it was shown to reduce albuminuria, but they were not able to demonstrate any improvement in hard endpoint of the kidneys. Now, for the finerenone, it is very exciting. There are actually 2 trials, Fidelio and Figaro. Fidelio looking more at kidney disease, Figaro more at heart disease. And you can see the numbers. They are amazing compared with earlier trials like Renal for losartan, DNT for irbesartan, and CREDENCE we just mentioned. And we're also looking at a wide range of kidney disease up to class 4. So I think we are spending a lot of energy finding new drugs, and I think it's very important if we want to offload the epigenetic luggage. But I think we are missing the elephant in the room, which is how we're leading our life, what we are eating every day. We should do that as well. So my last message is love your kidneys, and don't forget to look at our websites, renal.mu and the kidneyclub2020.wordpress.com. Thank you.
Any questions?